Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Jeffrey Hulburt, President and CEO of Beth Israel Deaconess Care Organization. Welcome.
Thanks, Matt. It's great to be here.
Yeah, no, it's great to have the leader of one of Boston's leading organizations on the program. So before we kind of start diving into some of the specific topics, do you just want to take a second to let everyone know who you are and what you do?
Sure, that'd be great. So again, it's Jeff Hulburt. I'm the President and CEO of Beth Israel Deaconess Care Organization, also referred to as BIDCO. And we're a value-based physician and hospital network and accountable care organization that's located in Westwood, Massachusetts. And my role is really to help the physicians and hospitals in our network to effectively manage the total cost of care for the patients that we serve, while also working to improve the quality of care that those patients are getting. I joined BIDCO as the CFO in 2013 and have nearly 30 years of experience in a variety of roles with both the managed care side of things, delivery systems, and health insurance companies. And prior to BIDCO, I was the CFO and COO at Network Health, which is a Tufts Health Plan subsidiary here in Massachusetts.
So kind of based on what you just said in terms of your history, I think you said you've been in healthcare for 30 years. So kind of what brought you into healthcare and what has been holding your interest for what I'm going to guess is most of your career?
Yeah, I grew up here in Massachusetts and went to school here in Boston, and actually was on a path to become a physician, actually, and got an undergraduate degree in clinical domain cardiopulmonary science. And this was back in 1985. And then for a number of reasons, I decided not to pursue the physician track, but got some of the best advice I had ever gotten from the leader of the pulmonary lab that I was running at Children's Hospital at the time, who said that managed care was taking a real hold back in 1985, and that if I wasn't going to move into becoming a physician, then business people who understood healthcare would be a great direction to go. So with that, I went on and got an MBA while working during the day. And then from there, just continued to evolve into a variety of roles, both looking at data analytics and ultimately executive management, both on the provider side as well as on the health plan side.
It's kind of interesting that you said back when you were trying to make your decision in terms of career path that managed care was pointed out as a particular target area that should be forefront of mind. So kind of how have you seen the evolution of managed care happen throughout your career?
Yeah, it's actually very interesting. And going back to those days and the conversations I had with the physicians at the time, back then managed care was this new concept of sort of telling physicians what they needed to do. I would say it wasn't received very well from the physician side, which was the reason I got some of the advice I got, was that they felt there was too much of a business aspect in healthcare. It's interesting going full circle to where we are today to realize that over the starts and stops throughout the 80s and 90s of moving into various levels of managed care, into capitation, and then moving back out of those type of payment models, ultimately arriving to where we are today in care that what we call today a value-based, really trying to manage cost of care while also paying very close attention to the quality. And I think the biggest thing I would say I've noticed in that change as I've worked in the various components is that we're now at a state where everybody sort of agrees, no matter which side you're sitting on, whether it's the provider or the payer, that these are the things that need to be done to bring healthcare costs under control while not decreasing the quality of the care that we provide. So there's, while we still have problems in terms of how we're going to get there and exactly what everybody's going to be doing from each side, there is a little bit more of a collaborative effort that's going on now than I think was there much earlier in my career.
Yeah, and kind of picking up on what you said, where it definitely feels like a more collaborative environment now. Can you give some examples of what form that collaboration is actually taking?
Yeah, I think that a lot of the arrangements that are being agreed to between health plans and providers today is much less about the actual rate that you're going to be paid for a certain service and more about managing an entire population. And I think both parties realize that, the end consumer is ultimately the patient who's needing services. And both a provider as well as a health plan need to treat that patient as a whole and figure out what is the best way to provide the services rather than doing it independently with each party not really paying attention to what the other is doing. So, for example, in a number of our contracts, we work very closely with the health plans on quality metrics and things that we need to be doing to be successful, not only for ourselves, but ultimately for the patient that's receiving care. So I think those conversations have evolved quite a bit. And, the emergence of the accountable care organizations, which BIDCO is one, really is a space that people like myself who've seen both sides of the equation can sort of come into that and help bridge that gap. So, I do still have a number of people in my network who are not as close to all the things that need to be done. And that's where BIDCO comes in, because we start to help those physicians and hospitals do the things that are necessary to be successful for themselves and for the populations that they're treating.
I think you had a number of thoughts there, and I'm going to pick on one and hopefully remember to come back to the others. But I'd like to kind of pick on the ACO or the ACO concept that you mentioned, and that, as you said, your organization BIDCO is a participant. And when you say participant, can you identify how many ACO programs or ACO models you might be involved in?
Yeah, so we have a number of contracts. Again, the market at this point is still somewhat bifurcated, meaning that certain patients, depending on who their health insurance is and how that health insurance is acquired, may be in these value-based contracts that fall within the ACO's domain, while others are still the traditional fee-for-service that you get paid for everything that you do. So, we predominantly are playing in all of the large spaces right now in terms of some of the value-based. We have Medicare products, we have commercial products, and we're about to embark here in Massachusetts on a Medicaid ACO product as the state is moving in that direction. That said, when you look at our practices, whether it be physician or the hospital volumes that are being seen, I would probably guess that we're somewhere not quite at a 50-50 split yet, probably a little bit more weighted towards fee-for-service, but significantly further along than we were a few years ago, where maybe only 5% to 10% of population that you're treating would be in the value-based contracts. So we're getting very close to being at that midpoint. And Massachusetts, I think, has been a little bit further along given some of the legislative requirements that occurred here in 2012 that have pushed us along that curve a little bit quicker than maybe at some other parts of the country.
Yeah, no, I think that's a very fair observation, one that's I find is always important to remind people who aren't from Massachusetts of, as you said, we've had more pressure to be moving more quickly into the alternative systems. But, as you were saying, it's, first you said, there's closing in on that 50-50 split between value-based covered patients and then the fee for service. And then also for that value-based component, that's coming across a mix of government and private payers. So when you're looking at all those different kind of programs, is there consistency across those programs, or is there a wide degree of variability that presents operational challenges?
Yeah, that's a very interesting question and one we deal with all the time. I think that it becomes one of the major challenges for an ACO. So I'll start with the positives, which I think at the highest levels there is consistency. It's essentially looking to do the right level of care at the right time and in the right setting to sort of maximize these goals of really managing cost appropriately and providing quality care. So at that high level, there is consistency. You know, one of the toughest challenges, especially for a physician treating a patient in their office, is they don't want to worry on a daily basis for each appointment they have of treating somebody differently and so forth. So they are looking for that consistent ability to practice care in the way they've been taught and in the way that they think is in the best interest of the patient. That said, there really are still some challenges out there, particularly in some of the things that are being measured to measure how quality care is being given. And right now, among a variety of our payers, the quality parameters that we're held accountable for do differ. And that is a frustration, I think, for a lot of physicians, because you know, there are a wide set of metrics. There are definitely some overlap. Breast cancer screening, you know, many of the standard preventative and screening tests are consistent, but then each health plan and even Medicare and the CMS have their own versions of what they're looking for to measure the definition of quality.
And given, as you said, you know, even though there's overlap, there can be slight variations. Do you see any standardization coming down the road, or any push from probably the provider side or to want to have standardization, so that way, you know, from one program to the next, you can have a better understanding in terms of what targets you're trying to aim for?
Yeah, there are conversations going on, and particularly here in Massachusetts, as a number of things have evolved. The legislation here is very active in trying to bring some level of consistency and talking about those quality metrics. You know, there are a number of constituents at the table. So you have individual health plans, you have individual employers who are providing health, you have the state doing its share. So everybody is looking to make sure that their definition of quality and so forth is being met. And yet there are conversations that are bringing that a little bit closer. I think, you know, one of the roles we play at BIDCO is, among that difficulty that exists there today, we try to provide a level of support where we can work with those offices to get them what we call the gap reports, to let them know which patients need to have which things done, so that we can do that for them as a business function without them having to make it a significant part of what they're worrying about as each patient comes through the door.
Right, and kind of thinking about the gap reports that you just mentioned, what have you seen to be the components that you've implemented that have been successful in driving success in a value-based world?
Yeah, I think, you know, data analytics and transparency are probably two of the most significant things that have to be developed first as you make this transition from fee-for-service to value-based. BIDCO made those investments several years ago as we came together. BIDCO was formed right after some legislation here in 2012. So in the early years of BIDCO and shortly after I arrived, we were spending a lot of time investing in the IT infrastructure, connecting all of the electronic health records and claims information that we had, so we could provide a robust data set that we could then analyze. And once we've done that, then we move to how do we take that information, get it out there in a usable format and in a timely format. I think one of the challenges, most of our contracts run on a yearly basis, so the metrics are over the course of a year. And very early on, we were always in that scramble in the last quarter of the year to try to get all of the patients who had to be seen with certain screening tests and other tests to be done in that last quarter. And what we've tried to do is to get that information to the practice much earlier in the year, so that over the course of the year they know, you know, for example, if they have a population where a patient has diabetes and they know that there's a certain test, hemoglobin A1C, that must be done each year, that they know that that's on their radar, that if that patient comes in for their annual visit, that should pop up and have that test done, so that they're not chasing it at the end of the year just to meet a quality metric. You're really trying to create an integrated approach where the day-to-day practice is absorbing all of these things that need to be done to satisfy sort of the ACO environment.
Yes, no, I definitely like what you just said of that you're trying to create an integrated approach. So you're not just trying to check a box, but really create a culture of best quality care. And for those of you just joining, I'm talking with Jeff Hulburt, who's the president and CEO of Beth Israel Deaconess Care Organization, about the shift to value-based care and ACOs. So as we were just talking about some of the successes that you've had at BIDCO with implementing value-based care, what are some of the challenges that you encountered?
Yeah, I think one of the biggest challenges is just that in order to be successful, there really does need to be change and transformation in the way the care is being delivered. And we're starting from a premise of where there's a long track record of how that care was being delivered, whether it be in the hospital setting or within the physician office setting. So, what we've tried to do, and one of the unique things about BIDCO is our approach has always been that in order to be successful in this environment, it really is going to take a partnering of our physicians and our hospitals in each of our communities. And the things that we do are, not every community is the same. We have 8 hospitals that are within the BIDCO network, and then the physician practices that are throughout the communities around those hospitals. And therefore, we look to each community and try to figure out exactly what the nuances are in each community and how they can work in that integrated approach. And we sort of are that backbone of providing services to really provide both the hospital personnel and the physician office personnel with what they need to make sure that that care is given an integrated approach.
Yeah, no, kind of what you just mentioned about, for your system, you're kind of spread across a few different communities, and that you're looking at each community. I know you talked about the partnership between the physicians and the hospitals, but can you give any examples of other providers or other types of resources in a community that you might be working with to be able, because thinking about with value-based care, I think a lot of the discussion oftentimes goes in the direction of like social determinants of health or population health. So thinking about the patient population holistically as opposed to just when they're in the provider's office or facility.
Yeah, that's a great point, and I think I have several examples. And again, our network is made up of hospitals and physicians, but that is not the only setting for the care. So even I'll start with, you mentioned social determinants of health. So we have people on staff either in the BIDCO offices or also out in the community who are social workers, who are working directly with the patient outside of that physician office or hospital setting, in between when care is given in those settings, just to make sure that we're on top of what the needs are and how those patients are treated. Another example is that many patients, once they end up in a hospital setting or so forth, may need to go to a post-acute care setting, either a nursing home or a rehabilitation facility, prior to being able to go back home. And while those facilities are not part of our network, we have to work extensively and collaboratively with them in the community. What we try to do is to create a network of very high-value providers downstream or upstream that are outside of our network, and build those relationships, and then guide our physicians and hospitals to recognize who those key players are. And again, I think the biggest thing here, we keep coming back to it, but it is that concept of integration. If a physician's office is unaware that a patient was admitted to a hospital and then ultimately discharged to a post-acute setting and then eventually home, if they're not getting all of what transpired in that, then they're not going to have the complete picture the next time the patient comes in, or even if that episode results in an immediate need to interact with them again. So we really try to do that. We have, as I said, people that are working in our clinical departments within BIDCO, care managers and social workers, who are trying to make those connections to make sure that all the right information is getting to the right people along the way.
Yeah, no, and that, development probably of, I don't know if infrastructure is the right word, but that development of the integrated network, really seems to be a essential factor for success in value-based care, which had been not necessarily not desired previously, but since there wasn't necessarily reimbursement to help cover the expense of that, it was hard to implement in a fee-for-service world. From what I'm able to read about, that the shift to value-based care and the creation of those broader networks as you were describing.
Yeah, I think, that's some of the dynamics within a fee-for-service world is that that type of incentive system allows each individual to focus purely on what they're doing and how to maximize that value without any consideration for what others connected next to you, upstream, downstream, are doing. And when you move to these value-based payments that are really about, and they all start primarily with a primary care physician who's in that role of sort of being the coordinator of how all the care is being delivered, you then begin to have conversations that go beyond just, I'm going to do this and this is what I always do. We're actually looking out for the best interest of the patient. I mentioned a moment ago some of the post-acute services. But additionally, we've also done some work over the last couple of years where we've been very adamant about when a patient doesn't need to go to a post-acute care and can actually go home. And we participated in one of the Medicare, it was a pilot program called the Pioneer ACO. And, through that model, we developed and received a waiver of a requirement of needing a 3-night stay in a hospital before somebody could be admitted either sent home or to post-acute care. So we tend to try to do what's right. And find a way to do what's in the best interest of the patient while maximizing the services that they're getting.
Yeah, no, and I know you've said that a couple times that everything you're trying to do is the best interest of the patient, which arguably is the only thing or the primary thing that the healthcare system should be trying to think about, since it's really fundamentally about caring for individuals and trying to ultimately avoid having to come into facilities because you want them to remain healthy, recognizing that there are certain times where it's unavoidable, on that kind of the flip side of that.
Yeah, and I think we've all heard those stories, particularly potentially with the elderly population, as that is a population that as you age, you potentially need more services. Those stories, they see 3 or 4 different specialists. Those specialists aren't talking to each other. The primary care physician's not involved. And before you know it, your parents or grandparents are on 16 different medications, unaware of what interactions are happening, can't figure out why they're not getting better, why they're still feeling ill. And you realize, it's more than just words on a page. It's really about the quality of life. And if you can really have that integration where the systems are talking to each other, I keep coming back to that because there is a technology aspect here that I think is critical to the direction that we're going. I oftentimes say to my staff and others that I work with, I look at the banking industry and the changes that have happened in my lifetime from when you used to go to a bank in person and have to do that to now I have daughters that just take pictures of their check on their phone and do everything electronically. And there was a technology solution there that allowed things to move that industry to a different way of servicing the customer. And I think healthcare is in that vein as well, that there are many things from the medical and clinical technology that we've already taken advantage of. And now we need the systems begin to talk to each other to make sure that information is being used effectively.
No, I think that's a very good point. And it kind of is making me think to come around full circle to think about, how you were saying at the beginning that, you were told in the mid 80s, think about managed care. With all that, with that technology that's now available today, do you see that maybe that was a missing component back in the 80s, early 90s when managed care was trying to be thrown out there as a major shift for the system, and maybe it wasn't quite ready, but now the tools exist in the current modern, in 2017, 18 to actually drive success because you can be able to take advantage of this, like I'd probably say 20 years ago, an unfathomable resource.
Yeah, I would agree with that. I think, it's sort of, you were asking people to do something without the proper tools to do it back then. I remember, even my first job working on an IBM XT computer that had less computing power than probably my cell phone does today. And yet we were asking people to do all of these things we just talked about without those tools. And then if you look at the progress that's been made with electronic health record, some of that's been driven by regulation and incentives that have been created by the federal government. But I also think it's an integral part of the way an office needs to practice. I can remember the days of going into file rooms with huge paper files on patients. And now I can go into my primary care's office for my annual visit, and they'll be sitting next to me with a computer, pull up everything that's happened to me over the course of the last year, check on it, and we just have that technology that's available. And at the same time, if anything is done in that visit, by the time I walk out of the office, the pharmacy's already working on any medications that I need. The front desk is scheduling any additional appointments I need. All of those things really are driven by some of the technology advances. And I don't think those things were really there in the way they needed to be back in the mid-'80s and early '90s to try to be successful.
Yeah, no, as you said, the development has been amazing. But believe it or not, we're already out of time. So I want to thank my guest, Jeffrey Hulburt, for a great and extremely fast-paced conversation today.
Thank you very much, Matt. I really appreciate the opportunity.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.